Hi folks, this is John Adamson, the Rehab and Documentation Guru, making a video because one of my patients canceled. And it's related to a memo that's been going around related to input, a memo that was received by therapists who are obviously treating in the inpatient Part A setting impacted by PDPM changes. And in that memo, therapists were instructed that for PT and OT, they could have a combined total visits of 6 visits only, and that was it. And then there's some guidance that is provided by these upper management people in the company suggesting that one, therapists need to be mindful of the fact that there are changes in payment. Well, that's nice, and there are changes in payment, but changes in patient delivery of care, that didn't happen. Your patients that needed medically necessary care prior to October 1st still have the same needs after October 1st. So when management was pushing you, saying that you needed to see a patient for this much therapy because of clinical need, you should have the same clinical need now. Medicare has made this very clear, abundantly clear through multiple presentations, some of which you can find on YouTube yourself. So that should not have changed. But we do know that practically there will be changes. I mean, one newspaper article that I looked at, I should have paid attention to the source, but it talked about how some agencies, rehab agencies, generally they have a profit margin of around 15%, although some suggest it's even lower. Well, I'm not I'm not sure who's suggesting it's lower, but having been in an operations world prior to PDPM, I know profit margins were generally running a bit higher than that. And you can correct me if I'm wrong from your agency, but in reality, profit margins were there. They might be a lot less now, obviously, with PDPM. And so companies are struggling to stay in business. But the ones that are going to struggle the most are the ones that had unethical practice before October 1st. But with that said, one of the things that this memo talked about was that your visits should be education heavy, emphasis on education of the patient. And I addressed this in a video the other night that a lot of what we do is not educational. And one of the things I address in my course, Documentation Bootcamp, is I talk about the fact that when you are trying to push care often onto somebody that's not a skilled therapist, whether it's the patient or a caregiver, one of the things you need for quick and effective and safe turnover is you need a high level of cognitive and psychological performance from the person that you're training. So that might work in a SNF where they should be hiring competent patients. No snickering laughter at that statement. But anyway, they've got to be able to have staff that's competent. They've got to show that competency to state and federal regulators to show that they are capable of doing some of these things. But let's face it, even if we educated our CNAs in these inpatient settings in 3 visits total for PT, 3 visits total for OT, if we educated them as well as we could in those very limited visits, they would not be able to safely and effectively manage most of our patients that are going for inpatient rehab. These patients are medically complex, and we are going to see more and more push for a higher complexity of patient in inpatient, and some of the patients we see as complex now are going to be shifted to home health beyond, not in the SNF setting so much. So you've got these highly complicated patients, and we're dealing with non-therapists and expecting to educate them within 3 visits for a discipline. That's just not going to happen. And so this memo is giving bad advice. Yes, we should be education heavy. One of the other points this memo brings up is that discharge planning must happen at the first visit. That should be already happening anyway. When you are formulating a care plan and you write your long-term goals, that goal is an indication that you've formulated a discharge plan. So you're beginning discharge plans right from the beginning. This has not changed since PPS going into PDPM. This is already happening. And to say that therapists should be always sticking with 3 visits total for their discipline for these inpatient, complicated patients is not only ethically sound, it's not clinically sound. You need a high level of competency for the people you're training. And let's face it, the people you're training already have other duties that they're supposed to be fulfilling, like taking the patient to the bathroom and getting them dressed and making sure they get fed and things like that. And so they're not going to get to all the things that you are needing to do. Now, should the facility in those cases hire more people, CNAs, to do things, or restorative aides to do things with the patient that you don't need to do? Well, absolutely. In this new payment paradigm, they better be doing that, because with reduced therapy staff, who else is going to be doing some of these activities that will produce the outcomes that this new outcomes-based payment model is designed to address? They need to have more non-clinical staff, but they don't have the expertise to deal with the unstable clinical presentations that a lot of these patients have. And so, again, limiting patients to 3 visits per discipline is not only unethical, but it's not clinical. And so, whenever you see these impositions of visit ranges across the board for all your patients, question that immediately. And please gently and persuasively stand up for what is right from a clinical perspective for your patient, because my concern is remembering what medically necessary care is that it's so complex that only you could safely and effectively do it. Is if we are pushed into these models, number one, your care will not be as complex as it should be to justify your care. And we will still be scrutinized in the future for the complexity of our care. Number two, it won't be as safe. If you're going to be passing off patients that quickly, chances are somebody's going to make a mistake down the road. And effectiveness. We live in an outcomes-based payment model. If you're dealing with complex patients, you need people who are critically thinking in complex ways, which means that they have licensure with lots of didactic knowledge behind their skill set and that license to safely and effectively do the care. So they're going to be the most effective means to get the patient in and out of Part A services quickly. And artificially limiting them to 3 visits is not going to work. Anyway, this is John Adamson, the Rehab and Documentation Guru, talking about the memo that's been circulating about the unrealistic expectations of therapy staff. I hope you have a great day. Be advocates for your patients. God bless and take care.